So welcome everyone. Thank you for joining us for Grand Rounds today. Before introducing today's speaker, I wanted to make a couple quick announcements. First, I want to encourage people to continue to monitor updates about the vaccine. You should be receiving emails from this about this from our infection control team. Second, our Grand Rounds next week will be from Dr. Robin Harris, who will be presenting on brain mechanisms underlying psychedelics. So today, it's a real pleasure to introduce one of our very own, Dr. Katherine Elkington. Kate grew up in Great Britain and then did her undergraduate training at the University of Michigan, majoring in psychology and graduating with honors. She then did her PhD in clinical psychology at Northwestern University, where she started her work on mental health among juvenile detainees. After completing her PhD, Kate moved to New York for her internship and then did her postdoctoral training at Columbia at the HIV Center. And we've been extremely fortunate to continue to have Kate working at Columbia ever since then. Kate has worked with Milton Wainberg on his studies of HIV prevention. And then she joined Columbia faculty in 2009 and was promoted to associate professor in 2016. Dr. Elkington has received numerous grants from various sources, including NIDA and NIMH, as well as several private foundations. Her work focuses on improving care, particularly for HIV and substance abuse among individuals in the juvenile justice system. She's published over 50 peer-reviewed publications, and in addition to her research, Kate is also highly involved in education, working as the training director for the T32 postdoctoral fellowship in the HIV Center. And so with that, I will turn it over to Kate, and we look forward to your talk.
Thank you very much. So just in the interest of transparency, we are in my house right now on full quarantine lockdown. We had a COVID exposure. So you may hear the dulcet tones of my children as they fight with their father to do remote learning in the background. So I do apologize, but these are the times in which we live. So today, I'm going to speak with you about the missed opportunities that exist within the juvenile justice system to identify and link youth to treatment for behavioral health or psychiatric disorders. So I first of all just want to acknowledge a number of grants that the data that I'm going to present with today are drawn from, both NIDA and NIMH. So briefly, the overview of the talk today, I'll provide a quick run through of the justice system, just how it works, so everyone understands the various components that we'll be discussing today. Then I will move on and talk about the high rates of behavioral health disorders among justice-involved youth, the context of risk, and then also their service use. We will explore the justice system as a critical point of intervention, and I'll talk about the particular activities that are currently going on. And then finally, I will present two interventions, multi-level interventions that have been developed by myself and members of the Center for the Promotion of Mental Health and Juvenile Justice, along with Gail Wasserman, our fearless leader who is semi-retired, but forever with us. And so I'll talk about these two interventions and their impact on improving identification and treatment access. Also, just as a note, as we go through, if you do have any questions for clarification, I know some of the things that we'll be discussing today perhaps aren't familiar to some of you, please just write a note in the chat, and then Jonathan can stop me midway through and just ask. Otherwise, we'll have a larger discussion at the end. Okay, so this is a diagram that you see here. It's a simplified sort of schematic of the juvenile justice system in the US. It varies somewhat by state, but largely it sort of resembles in some way this form. There are three general components or I guess four general components to the justice system. So upon arrest, an individual can enter the system in a variety of ways. So there are all these complicated arrows that shows you sort of how everything is interconnected. So they can either go through the section of community supervision, where a youth will receive an intake, and that's where they do a full assessment. And at that point, it can be determined that they can be informally supervised on probation, or they may be referred to family court for formal adjudication with a judge. And then potential result of that sentence will either be to detention, which is more of a short-term stay, or to secure care, sort of very similar to adult inversion or incarceration. A youth may also be sent directly to detention after arrest, and they will be held there until their court proceedings. And then at that point, they will be, disposition will be passed down, and they will be either returned to detention or again to secure care, or even go back onto community supervision. You can see there are arrows that kind of disappear at each of these points, noting that this is where a youth can exit the system in general. However, once involved in the justice system, it's very difficult to disentangle yourself from that web. When you are, particularly, for example, if you're coming out of secure care, you go back to community supervision for aftercare programming. You're still under community supervision, despite the fact that you may have completed your secure care sentence. And so if you fail to complete the terms of your community supervision programming, you don't attend meetings and so on and so forth, you can be sent back to secure care. And so the cycle continues. Just some basic figures. As of 2017, youth who are on formal probation, so that's the community supervision section, majority are male, about 42% are white, 36% are African American, and 19% are Hispanic. However, you see racial disparities start to increase as we penetrate deeper into the justice system. So here you see minority youth comprise 62% of the court population, yet 34% of our national juvenile population. And African American youth are 5 times, and Hispanic youth are 2.5 times more likely to be detained compared to white youth. And I'll pick up the point about sort of racial disparities later on in the talk. So let's just review the overlap of behavioral health problems among justice-involved youth. They have disproportionately higher rates of disorders compared to youth in the general population. Anywhere from 25 to 67% have a substance use disorder. As many as 60% have a mental health disorder, and substance use is endemic and ubiquitous. 75% of juvenile arrestees have substance use or addiction involvement. And then the specifics here, you can see the rates of anxiety, mood disorder, and then the high rates of PTSD and trauma. Alarmingly, 11 to 32% report a lifetime suicide attempt, and this is compared to the 3 to 9% that we see in the general population. The graph on the right here shows just the rates of, this was a study that was conducted by Gale and Larkin McReynolds, published in 2010, and they reviewed data across 18 states, about a total of 10,000 youth, and generated rates of substance use and mental health disorder. And you can see here that as you move deeper into the justice system, so from probation to detention to secure care and incarceration, you see the rates of disorder go up. And then this is obviously in comparison to the general population. Outcomes associated with psychiatric disorder in justice-involved youth are pretty problematic. Alarmingly and importantly, they are associated with higher rates of reoffending and violence, so continued criminal behavior, increased rates of risky sexual behaviors, reductions in academic treatment, and then, as I noted, heightened suicide risk. And so it really becomes paramount if we are going to try and stop the cycle of justice involvement for these youth, and to present their persistent and escalation of their behavior, particularly into adulthood, so that they're transitioning from the juvenile into the adult system. It's important that we treat these disorders so we can improve long and short-term outcomes. So the context of risk for disorders in justice-involved youth, why are their rates so high? Well, there are numerous risk and very few protective factors to offset the risk for justice-involved youth. And so these factors promote both their justice involvement and also increase their risk of psychiatric disorders. Work by myself and other colleagues in the field has identified how risk can further compound, it's further compounded across multiple intersecting systems or domains in which the youth exist. So for example, in neighborhoods characterized by poverty, violence, crime, high community substance use burden. In the family system, we've seen greater conflict, less support and monitoring from parents, poor communication, and then the caregiver themselves with mental health and substance use, and also histories of trauma. Justice-involved youth also seem to gravitate towards more antisocial peer networks associated with school dropout, expulsion, and truancy, and the youth themselves have substantial histories of loss and trauma, and physical and sexual abuse, all known to increase the risk of psychiatric disorders. Now, while this may look rather a bleak visage, if you will, or context of risk, there have been specifically evidence-based treatments that have been successfully developed for justice-involved youth. Many of them target mental health and substance use together, and the overwhelming majority work with the youth and in conjunction with their family. And also, this is not to mention that there are other evidence-based treatments available in the community that these youth can also access. Yet, despite the availability of treatment, we see time and time again that between 50 to 90% of justice-involved youth do not make it to treatment. So, thinking about this context of risk, there are potential systems that may be amenable to intervention so we can try and increase service access for these youth. And in particular, one such system is the juvenile justice system. Community supervision in particular, I want to present here as at a critical point of identification and intervention. So here you can see on the diagram, community supervision is one of the earliest stages of justice involvement following arrest. And now community supervision settings are potentially ideal places to identify behavioral health problems and link justice-involved youth to care. First of all, they serve the overwhelming majority of justice-involved individuals. And this number, 260,000, represents those who have been formally adjudicated. There are many more youth who are informally adjudicated, so they go on community supervision. They're maybe diverted or adjusted, the phrase is used, rather than formally go to court and receive a formal sentence from the judge. But this is compared to about 55 to 56,000 youth who are in detention and secure care settings. The probation, which is part of the community supervision setting, has been nicknamed the workhorse of the justice system for good reason. And so in these settings, it potentially allows us to access and identify really high-risk youth who unfortunately are not likely to be linked to services in the community, and we're not able to find them when they're not justice involved. And then finally, the community supervision agencies are charged with addressing recidivism and promoting rehabilitation. That is their mandate. And because we've seen that behavioral health disorders are on the causal mechanism, if you will, causal pathway to recidivism, community supervision agencies really do see it as part of their mission or their mandate to link these youth to treatment and care. So I think it's important to explore what exactly happens in these community supervision agencies so we can see what services are being provided. This is a national survey that was recently conducted by Chris Scott and Mike Dennis out of Chestnut Health Systems. And here they surveyed about just over 3,200 community supervision agencies across 20 states in the US. And they wanted to identify what were the services that were currently being provided directly by the agency. And here you can see that the majority do screen for behavioral health disorders. And of this 64%, about 83% were using evidence-based tools, which is excellent. However, beyond screening, you see that clinical assessment, substance use treatment, and mental health treatment are much less frequently provided by the agency. And so at this point, the community supervision agency has to refer youth into the community in order to receive these services. Now, the behavioral health care cascade is a useful rubric, if you will, for identifying where youth may sort of fall off the cascade when they're getting from treatment, when they are being screened and to identification of their treatment need to ultimately enrolling in treatment within the system. And so this is data that were originally, so the behavioral health care cascade was generated or developed by Steve Valenko. Some of you may be familiar with these care cascades as with HIV as well as the opioid care cascade. So these data are drawn from JJ Trials, which was a large multi-state, multi-site research cooperative that was developed in partnership with NIDA with an eye towards really improving the access of evidence-based practices that would target substance use and HIV risk behaviors among justice-involved youth. So this care cascade that you're looking at demonstrates substance abuse screening and ultimately linkage to care. And I'll walk you through it. So here you see about 8,300 youth, where went through intake. Of those, about 71% were screened. And of those, about half were flagged as needing further assessment or clinical intervention of some form or another. And then we go down here and we can see that of the 4,000 or so youth, only 940 of them make it to, are referred to behavioral health treatment. So just over 20%. And then the cascade gets shorter and lower even still. Of those who are referred, about 67% of those who refer do make it to treatment, but it's only 15% of those who are identified as being in need of services back here. And then further still, you can go on and see that of those that initiate treatment, about just under half remain in treatment over 6 weeks, but that translates to 6% of those youth who are identified as being in need. In particular, you can see here that there's sharp decline in a large fall off of the care cascade happens between screening and referral. And this side of the care cascade happens within the community supervision agency itself, as opposed to this happening within the treatment system. And so we can see here that there's a huge drop off with referral and indicating a potential place for intervention. Work by colleagues in the field has identified that referral is associated with greater perceived probation officer perception of support from a supervisor, their perceived innovation and flexibility of the organization that they're working in, and the importance and relevance of referral. Not all probation officers hold referral in this regard. We also see that a probation officer's referral is influenced by their own perception of the youth's treatment need, and then the youth's gender and race ethnicity, with females and white youth more likely to be referred for treatment. And so the idea here is that we have an opportunity to address a missed opportunity within the justice system. And so we developed a program called eConnect. And eConnect was drawn from Project Connect, which is the original blueprint. Project Connect was developed by Gail Wasserman. And it was a project designed to help and facilitate probation officers to identify and then refer youth accurately to treatment within the behavioral health system. It was a paper or pencil approach. So this was over 10 years ago. And it was successful. It was efficacious. It had a twofold increase in the number of youth who were able to get to care. Yet 50% of the youth still did not make it to care following Project Connect. Also, the project was not sustained. It was very difficult for the probation officers to deliver. And so a year later, many of the activities were no longer ongoing. And so we decided to revamp Project Connect, and with a focus on really using technology. And so we developed a web-based application that we can install on tablets and implement in community supervision agencies. And it seamlessly combines screening, classification, and county-specific real-time referral decision making, so that probation officers know exactly where to send the youth when. It also removes probation officer bias, is the hope, in that the youth completes the screening themselves, and the tool then tells the probation officer who needs to go somewhere and where. The probation officer does not have to make those sorts of clinical decisions. And so we conducted a trial to examine whether or not there are in fact improvements of screening, identification of suicidal behavior and associated behavioral health problems, referral and treatment initiation. So the trial is currently ongoing, and we're working now in 10 counties in New York State. And we originally developed a step wedge design, which I can explain more about that in a little while. And there are basically 5 activities that go along with project with eConnect. And so I'm going to walk through the activities 2 through 4. So once the probation officer has prepared everything and is ready to implement the tool. So first of all, the youth completes the screen. It's voiced. So if the youth has any difficulty with literacy, they can simply click on one of the questions and they'll hear it. The question will be read to them. They're given headphones and they can complete it at their own pace. For the screener, we used an adapted version of the GAIN short screener, or the GAIN SS. And so the GAIN has 4 subscales, but we only used internalizing and substance use disorders among this population. We chose not to use externalizing disorders, given the high rates of conduct disorder among youth in justice settings. We felt like we'd get a lot of, it would be sort of too sensitive. And then we also removed the crime and violence disorder subscale as well. Finally, we also tweaked the response options. So we added additional information about the recency of symptoms. So we included information about 2 to 3 months and 4 to 12 months as well. To get more information on suicidal behavior, we integrated items from the GAIN-I, which is a full-length assessment tool, and we ascertained more specific information about plan, intent, and recency of suicidal ideation. And then also we included non-suicidal self-injury items as well, looking at method as well as recency and frequency in the past 90 days. So the second step, once the youth has completed the screener, it is scored in real time, and the level of risk is then calculated right then and there on the tool. And we generated 3 classes of risk. Class 1, which is crisis or an imminent risk, and a youth that would require pretty imminent or immediate attention. Class 2, the youth is in crisis but not imminent, so clinical intervention does not need to happen immediately but should happen soon. And then finally, we have a class 3, which we commonly refer to as standard behavioral health referrals. So those with elevated internalizing and substance use symptoms, but not rising to the threshold of crisis. And so the classification, we generated an algorithm in order to determine combinations of symptoms as endorsed by the youth on the screener and how they would go into these 3 classes. And so here you can see the combinations of the different suicidal behaviors, in addition to internalizing and substance use disorders, and the timeframes that go along with each. We are in the process right now of validating this approach, comparing this to both actuarial assessment in the field, so clinician and mobile crisis evaluation of the youth that they met with, and then also to the Columbia screen as well. And then on the right-hand side, you can see the response to each class, which was emergency clinical care, evaluation within 72 hours, and standard referral. This classification erred on being conservative because we knew we would be identifying youth who, for some, had not identified or had been unidentified with having suicidal behavior in the past, were likely not linked to care. And so this was probably a conservative assessment. Then finally, once the risk class has been determined by the tool then provides a county-specific referral pathway. these are determined, and this is a really key piece of this project of eConnect. Before eConnect even rolls out and the probation officers utilize the tool, there's a meeting that's held, or several meetings that are held between the county stakeholders, behavioral health and juvenile justice. And they get together, they review the types of youth that eConnect would be generating, so the classes of risk, and determine together where these youth should go. And also the appropriate response and who is going to respond to these youth. So for example, for a class 1 youth, who's going to come out to probation and see that youth? Or is it that there's someone who's going to transport them to the ER, and who is that? These nuanced discussions and very careful determinations of where specific youth will go result in pathways, and it allows the referral pathways, and it allows the probation officer to know exactly what to do in the moment. And so finally, a referral form is generated as part of the tool, and it is to be provided with either the crisis responder or sent to the behavioral health provider, and just enables the youth to, once they get to the appropriate location for their clinical need, it allows that clinician, upon receipt of that youth, to really have a very clear understanding of what's going on and why they're there based on the symptoms that they endorsed. So I'm now going to present to you some preliminary results. These are really hot off the press, and we have some more digging to do, but I wanted to share these with you. So we've been doing eConnect now, implementing it in the field for just over a year. And we've e-connected, if it's a verb, about 556 youth. And of those, we've identified 14% as youth who we would consider in crisis, 3% of class 1s and 11% of class 2s. And then class 3s, we had about 25% of those. And here you can see our estimated numbers based on prior data on GAIN items and their frequency of endorsement. We generated rates of class 1s, 2s, and 3s that we estimated we would in fact identify, and we're reasonably close to those rates. And so here we can see, compared to baseline, so this was what was going on in the counties where we are currently working before we rolled out eConnect. And these data are all pulled from administrative records. And you can see here, we're seeing significant differences across the board at each of the key steps of the behavioral health cascade that we were targeting. Specifically, we increased the number of youth who were screened by a factor of 1.9. Interestingly, we decreased the number of youth who were identified with a behavioral.
Simon, I think we lost Kate.
I just noticed that. I think that's on her. She just probably lost connection on her side. Dr. Liebman, you're muted.
Her mute button is on.
I don't think that's even her.
Can you unmute her?
I just asked her to unmute herself. I don't think that's her.
That's strange. Well, Jonathan, so just to prompt some questions you can ask when Kate gets back online. Anybody have her cell number?
I do not. I'll try to email her now.
Okay. So I had asked about, what the role of learning disabilities might have been in terms of the incarcerated youth. And also, do they have follow-up data, through or into adulthood to have any information about what the psychiatric outcomes of these individuals might be? Okay, cell is this? I'll call her.
Okay, great.
Chairman's work is never done.
Thank you, everyone, for being patient with our technical difficulties. While we're waiting for.
Okay, we lost your connection. Okay, it's a local router. If you don't, call me back and I'll just patch your voice through and you can talk through your own slides, okay? All right, bye. So she had a local Wi-Fi failure, and she's trying to use her smartphone hotspot.
Okay. Regarding your question about learning disabilities, Jeff, I'm obviously Kate could answer this much more in a much more informed way than I could, but I'm sure you're right that those are very, very common. What I suspect that many of those children or teenagers also have ADHD. And if I understood her design correctly, they were screening out for ADHD. So they may not be well represented in her sample. Oh, there you are, Kate.
Can you hear us, Kate? Can you hear us?
And I'm so sorry about that. My internet just completely cut out.
Blame it on the Russians.
Let me start again. Okay, so this is where we were. The peak of the presentation, of course. So I had just said that we had increased rates of screening. We decreased identification of the number of youth with a behavioral health need. And the reason for that, we believe, is because before we began eConnect, they were not using an evidence-based screen to identify mental health and substance use behaviors at all. There were what the probation officers were using was something called the YAZI, which was an evidence-based tool, but to address risk of recidivism. And so as part of that assessment, they do inquire about mental health and substance abuse needs and prior treatment history and so on and so forth, but is by no stretch a careful symptom assessment. And likely they were over-identifying youth who needed treatment. But then when we look at the number of youth referred, we're over 15% an increase here of youth that once they were identified, they were referred. And then finally, which I think is pretty amazing, of the youth who were referred, we see 71% of them actually initiate treatment as compared to 19%. And that's an odds of 10 times, over 10 times more likely to initiate treatment with eConnect than just with a youth probation officer making referrals themselves.
Kate, one question that came up while you were offline was, could you tell us the age range of the kids that you're working with, and also whether learning disabilities were assessed?
So we did not assess learning disabilities, but the age range of the youth, I'm sorry, I should have mentioned that, is in New York State, it is juvenile probation is between 10 and 17 and 11 months. So once you hit 18, you would be considered an adult in the adult system. Okay, so then specifically looking at identification of suicide risk, again, the rates of suicide attempts are astonishingly high in this population. So looking at classes 1 and 2 combined and our ability to identify and link these youth to care. Here you can see over the 12-month period of time, we were able to identify 78 youth compared to 24 at the baseline period. And at baseline, they really were not systematically identifying youth suicide at all. It was more a sort of a happenstance approach if it was identified during a supervision meeting with a probation officer and the youth or the youth's family members. And then of the 78 youth that we identified during eConnect, 100% of them made it to care and received a mental health touch. Compared to only 20% of the youth at baseline who made it to care. The large majority was unknown ultimately what the clinical intervention was that they received. Now, the thinking of the contextual risk that I described earlier, serving as barriers to service use, there's also an additional system that is amenable to intervention, and that is the family. And so while the eConnect has shown significant promise to increase referrals and initiation of treatment, it does not work at all with the family. It's truly working at the level of the community supervision agency. And as we know, family is critical in treatment outcomes for youth who are enrolled in psychiatric care. And similarly, family involvement and engagement is associated with much better outcomes for youth involved in the justice system. Yet family engagement, as with in psychiatric treatment, is very hard to achieve in probation settings and community supervision settings. And so we sought in a small study, we sought to explore what are some of the experiences of justice-involved families that they may have while seeking care, and to identify potential barriers to families choosing to take a referral and initiate care for their youth. And these youth are typically those who we would consider the class 3s of eConnect. So these are not youth who are in crisis, but youth who have been suggested by probation officer or even mandated by court that their youth should engage in either mental health or substance abuse treatment. So we spoke with 10 families, so a youth and a caregiver dyad, 15 probation officers, and 30 substance use treatment providers. And we identified several themes that came up that seemed to serve as potential barriers to the family experience. The first was distrust in the system. And this is a mother who reports, the system doesn't really care about anybody. Okay, this is going on. We're going to go over there and we're just going to split everybody up. And so why should we talk to them? Why would I let my teen go? And so it was a real concern and a fear about how the treatment system would manage their child. And these are families who are multiply system involved, and potentially not just the youth, but the parents themselves. And they've not always had the best experiences with this system. And so this trust has been, I think we could be fair to say, has been well earned. Another barrier that emerged was fear and shame on the part of the parents. And treatment providers saw that as a fear of what they were going to hear in treatment, what spotlight was going to be shone on the family that perhaps the parent or the child didn't really want anyone else to know about. And then the parents also talked about shame, that they had a child who was using substances or needed mental health treatment, and that it was somehow their fault. My mother replies, everybody tries to focus on the parents. They try to find out where the problem could have started or what could have caused it. But no, I don't beat my children. There's no sexual abuse. I don't drink and I don't smoke. Another prominent barrier, as described, was the relationships difficulties within the youth's family themselves, and particularly between the caregivers and the youth. One substance abuse treatment provider describes it as thus: they want to slow down the car and dump the child here and then keep going, which is understandable because they're done and they have very little hope. And so because of that, they're less likely to want to be engaged in that youth treatment. And then finally, both probationists and treatment providers noted that the families themselves were extremely taxed, and there was a considerable amount of burden within the family managing and navigating many complex and competing requirements. And as one probation officer notes, the treatment system's expectation that the youth attends a program 3 times a week. The kid is dependent on a mom who works overnight. She's not available to drive him to treatment, and they don't have the money in their grip. And so these were 4 prominent barriers that we identified as to why, when given a referral, a family will not engage their youth in treatment. And so we developed a program called Family Connect, and it was a small pilot demonstration project in order to increase the coordination between family treatment and justice systems, and to then ultimately increase uptake in treatment and care. And the crux of Family Connect was to use a linkage specialist who was going to work with all 3 systems, if you will: the family system, juvenile justice, and the treatment system. And here we would be able to decrease the probation officer burden, so they wouldn't be responsible for making all the referrals and managing the follow-up, and also coordinates better between the probation officer provider and then supports the family in so doing. There were, as part of the Family Connect protocol, the linkage specialists had to complete 5, we call them tasks, with each family. They can be completed in any order with the exception of the first. When the linkage specialist met with the family, and that could be whether at home or somewhere in the community that would be confidential, or even in probation, it was wherever the family felt most comfortable meeting with the linkage specialist. the first task that they would engage in was just developing a working relationship with that family, separating themselves from the treatment system and the probation system, and really sort of aligning with the family and helping the caregiver to see that the linkage specialist was an ally working in their best interest. And then the additional tasks were worked on depending on the family's needs and presentation. So clarifying the need for treatment and addressing perceived barriers, so stigma, that there's a denial of even having a problem, addressing potential relational rupture. There were many instances where parents and children just could barely sit in the same room with each other. And so the linkage specialist would work on addressing if they could just get them to sit in the same room and begin to work on attending treatment and ultimately family therapy. Again, addressing some concrete obstacles to enrolling in treatment. Transportation, insurance, and things like that. And then finally facilitating that enrollment, helping the parent make that appointment and get their youth to intake and beyond. And so, as I said, this was just a pilot. We enrolled 18 families, and then we had a historical control group that was generated based on 6 months of administrative data that took place before we rolled out Family Connect. And here you can see that Family Connect, we obviously were in the business of referral. So we referred 100% of our youth compared to 83%. And this was done in 2 probation agencies in 2 separate counties in New York State. We were able to get just over 2/3 of the youth to an intake appointment, either mental health or substance use. And then finally, of those youth, we were able to get 61% of them to remain in treatment for at least 1 or 2 sessions following intake. And again, not significant, we weren't powered to do so, but it looks very promising and is something that we're hoping to develop further. And so in conclusion, yes, we know justice-involved youth have disproportionate burden of mental health and substance use disorders, but their use of needed services remains low. Streamlined procedures, I think that really help integrate the justice and behavioral health systems appear to be key in improving screening, targeting, and referring linkage. And that can be done either via technology and also through embedded staff. And then finally, I think eConnect and Family Connect both show that system and family or individual level factors that frequently can serve as barriers to service use can be addressed and overcome, even in the most resistant of families or systems that are incredibly recalcitrant to change. The approach is potentially generalizable to other parts of the justice system. We currently have a project going on now where we are working with adult opioid courts or a specific treatment court targeting, as the name implies, adults with opioid use disorder and related problems, and working to generate very smooth and tight referral mechanisms so that these individuals can access medications for opioid use disorder, which are typically can be hard to come by for adults in the court system. And then, so next steps. Is eConnect scalable beyond 10 counties in 1 state? It took an awful lot of technical assistance from the Columbia team to roll out eConnect. It was not as hands-off as we had originally anticipated once the tablets went live in a given county. And so we're now struggling with the idea of how would we take this to another state, such as Indiana or Washington State, and train probation officers to do eConnect. And then finally, eConnect has great results, but we can always do better. And so would there be an argument to combine eConnect and Family Connect so that those youth who are identified as a class 3 would then be sent to work with a linkage specialist who would help them then get to that treatment in the community. And that's it. Thank you.
Thank you so much, Kate. That was a really, really terrific talk. And I just wanted to make, I guess, two comments before starting with the questions. So, first, it's really remarkable when you think that, on the one hand, the criminal justice system is the largest provider of mental health care in our country. and yet the amount of academic research actually being done on that care is so limited. And so really wanted to thank you and applaud you for doing such important and challenging work. And second, I also just wanted to note that doing grand rounds at your home institution is always stressful, and all the more so when your internet goes out midway. But you were calm and clear throughout, so congratulations. It was really, really terrific. So I will start with the questions. So there's a question from John Mann, who asks, your results in connecting suicidal kids to treatment are impressive, but are you planning to determine if it does make a difference to suicide behavioral outcomes?
Yeah, so that's a great question. The data that we're drawing from in order to look at youth movement through the behavioral health cascade in eConnect is drawn from administrative records. And so that, and the way that we get those data are largely de-identified. So right now we don't have the ability to then go over into treatment records and link those youth and identify what their outcomes would be. We can do a gross examination of suicide rates in the counties that we're working in, but I think that's probably a little bit too far removed. But I agree, it is something that we need to think about doing and being able to make that link, particularly potentially with Medicaid records, so that we can get a sense of outcomes in that way. One of the reasons that we get the administrative data in the way that we do and have it be heavily de-identified is in order to do this work and consent parents and children to participate in eConnect would be almost near impossible. And those families, and as I mentioned, families are very nervous, they're concerned, they've got a lot of sort of fears around what it means to have their child involved in the treatment system. And so you can imagine that those families that perhaps their youth most needed to be assessed and linked to treatment and care would refuse to do so. Also in New York State, and this is comes back to the step wedge design. During the course of this study, New York State made it mandatory that probation or community supervision utilized an evidence-based behavioral health screener for youth who are coming in, so adjusted JDs. And this had not been in place when we started, but all of a sudden, all of our counties, if they weren't actively using eConnect, they would have been considered non-compliant with the new policy. And so our step wedge kind of went from a wedge to a flat line. We had to roll everybody out at once. We've been doing this sort of like through accessing records, and at the moment that's the way that we're able to work it out.
Great. William Tucker asks, do the mental health and substance use providers feel comfortable asking about the nature of the behaviors that prompted the involvement of the justice system?
I think only when it's only, I think, part of the treatment when it's relevant. So if a youth has been referred by probation, the provider is aware of that. They're aware of the referral source, and particularly if it's a mandated referral, in which means that the provider also then has to do some more formal reporting to the court. So for the most part, they're aware of the justice involvement. Providers talk to me have said that they tend to only bring it up when it becomes relevant. Typically the idea of you don't want to be here, someone else is making you be here. So it tends to come up in that forum. I will say I have another project that I'm working in a courthouse with young adults, so 18 to 24-year-olds. And we're running a group to reduce substance use and HIV sexual risk behavior. And the youth rarely talk about their own justice involvement. They are open books about all other kinds of aspects of their lives, including trauma and things like that people might be potentially inclined to be more confident about or confidential about, but these youth are not, but they do not talk about their justice involvement. There's heavy stigma involved in that.
There was, I guess, a related question from an attendee asking about the adjudication process, and if a youth discloses that he or she has a psychiatric illness, the person who's writing in asked whether suspects that can make the outcomes worse or the sentencing more severe, potentially related to stigma. I guess thoughts about that, and is your sense of that actually does play a role?
So it shouldn't. Technically, it should not. We should not be using, and judges should not be using a psych hold or sort of hospitalization in lieu of detention or secure placement. But that does happen. I am not familiar with sort of specific work that's looked at that, but anecdotally, I have heard that. Particularly, it also happens with the adults as well. This is particularly true of over the past, I would say, 10 plus years. There's been a real shift in the juvenile justice system towards more rehabilitation. It's particularly in light of evidence that suggests that placing a youth in detention secure care doesn't actually result in better recidivism outcomes. Community supervision is much more the way to go. And so there's been a movement to shift youth from locked facilities into community supervision. And so in some instances, you may see judges using a psych hold, for example, in lieu of that, because they're not going to be able to sentence. But that's sort of anecdotally on my part. I don't know of work that specifically looked at that.
I realized that in your study you did not include externalizing disorders, but because ADHD is near and dear to my heart, I can't help but asking a question about it. We have pretty good data now, at least in adults, that psychostimulant use in adults with ADHD actually reduces criminality. But there's a real hesitancy among providers to prescribe psychostimulants for fear of diversion, particularly among people who have a criminal history. I guess I'm curious to get your thoughts on how that plays out among teenagers, where I think that the impact could be even more substantial.
Yeah, I would say that's also there. Although I would say that probation officers don't have such a nuanced understanding of it. I mean, there's certainly concerns about diversion of medications, or it be stimulants or medications for opioid use disorder across the board. But I think that the sense for probation officers is just really trying to get youth to treatment. And then what happens in the treatment system, they tend to, for the most part, probation officers tend to kind of stand back and say, I am not a clinician. That is whatever is going on there is what needs to happen. Sometimes there's differences, particularly with substance use disorder. If you've got a probation officer who's a little bit old school and they're kind of zero tolerance, we're not going to do a harm reduction, and you've got a therapist who's following a harm reduction model, then there can be tension between the treatment system and juvenile justice. But my experience has been generally probation officers frequently say, we are not clinicians. And that was actually part of the impetus for eConnect. They don't have to be. And so it alleviates that need.
Right. Okay, great. Question from Diana Martinez, who asks, any thoughts on ways to reduce stigma with the parents? I understand the parents feel blamed, and thoughts on changing this.
I've long toiled with this issue and really thought about ways in which we can address the stigma. I think it has to be a multi-level approach from probation officers, the way that they perceive the families. Some of them are able to express a lot of empathy, and they really see the family as a sort of a full unit with multiple competing demands. And then some can be sort of, oh, the apple doesn't fall far from the tree sort of approach, and can be a little pejorative. So I think that there's certainly some work that can be done from the sort of probation and juvenile justice side of things. But then also on the treatment side of things as well, we don't take these youth with open arms. They're expected that these are difficult families to work with, and and that clinics are very quick to close these cases. 2 no-shows, we're done here, and and so I think that there's work to be done on the treatment side as well. And then with the families themselves, I think that the work that I've done, the groups that I've run with parents, I'll have an agenda, certain like sessions that we're going to do and things that we're going to cover. But the first session always is the parents bonding together and talking about their experiences of stigma, and sort of creating a shared bond about having a child that's involved in the justice system. And so I think also too, among the parents themselves, they generate a lot of support from each other and kind of talk about how this isn't their fault, and they're doing the best that they can.
This question from Cristiane Duarte, who writes, wonderful talk. Did you identify any age effects? For example, are younger children more likely to do well in Family Connect?
So in Family Connect, because we only had an N of 12, I haven't really been able to do anything there. And for eConnect, we do have those data. We need to look at them to see particularly age, gender, and race ethnic analyses. So that's our next step, to look to see if there are differences by those key demographic variables. In the past, younger youth are more likely to be referred. Probation officers are more likely to refer younger youth. So it'd be interesting to see if that changes, and if there's no age effect of referral, there may well be of initiation. Parents have a little bit more control over the little ones.
Wonderful. Okay. I think those are, oh, no, there's a question just came in. Wondering about racial breakdown in younger children, ages 10 to 12.
Just in general, or?
Yes, I believe so. If the racial disparity, I'm not sure, but I think the question is getting at whether you mentioned racial disparities and whether there are differences across the age range.
Oh, I see. That's a good question. And I don't know the answer to that. I do know that the race ethnic disparity that you see it kind of increase as you go deeper into the justice system, and I think that's net neutral of age. But within court populations, or within, I don't know the answer to that. It's a really good question. The numbers of 10 to 12-year-old youth in the justice system are low. The average age is around 15 to 16, and the bulk of them are between 14 to 17, and that's the majority of youth that we work with in eConnect. So your 10 to 12-year-olds are few and far between.
Okay, great, wonderful. So I think those are all of the questions, and so I just wanted to again, thank you so much, Kate, for presenting today, and really, applaud you on such challenging but impactful work that has the potential of impacting so many youth. And so we really look forward to continuing to hear about your work and learning about its progress. So thank you so much, and we will reconvene in a week.
Thank you for having me, and I'm so sorry about the internet.
Not at all. Thanks so much. Okay, bye.
Bye-bye.